And you're set to go, Karen. The time is yours.
Thank you. Thank you, everybody, for coming. I see some faces and names. Y'all make me feel so proud. Thank y'all. So Ellen and the Alzheimer's team has allowed me to come and speak to you guys regarding basically the differences between palliative care and hospice. We have so many families in the community that are just kind of trying to figure out, where do I start? What do I do? What's the difference? What do I need to do? So hopefully I can shed some insight on the difference between the two and kind of give you some information on where you need to start. Of course, if you have any other questions, please save them for the end. Or if you need to reach Ellen with any additional information, please reach out to her after this lunch and learn. So I would like to start off just by discussing what palliative care is. And basically, it is a level of care received by a team of members, which it can include a clinician, different type of team members that are focused on providing caregiver support in the patient's home or home-like setting, while maintaining the ability to continue treatment based on what they have going on. So, like Ms. Ellen says, palliative care would allow you to provide some supportive care, but still allowing them to receive whatever treatment that they need at that time. So the visits are really scheduled by team members. They can receive a doctor, a nurse practitioner, a licensed practice nurse, a social worker, a spiritual care provider, which is like a chaplain, and a volunteer. I will preference on this. I'm just speaking in general. So this is not particularly for a certain program. I would say please do your research, talk to your medical team. Each particular program that's offered in our community would have a different level of services. So this is just kind of what I've learned over time. The team members in palliative care do ongoing assessments, which is establishing goals for care, what they need to provide, what can help the family and their loved one in the home. We talk about education about the illness progression, particular medications, just what we may predict that may happen or what we could provide as far as education on what type of diagnoses they have or what we've seen before, or just questions about medication, what does what and what side effects may occur, just giving them more insight on what's happening on the medical side for their loved one. We also do symptom management, and based on the diagnoses, that can be controlling pain, providing services at home. It just really depends on the family and the loved one. We do talk about strategies for living with a serious illness, what that looks like. We also provide, or a program could provide, emotional, psychosocial, and spiritual support. We do like to provide assistance with difficult conversations, and that could be just kind of explaining what that is. We've had several family members, or I've experienced certain family members just have hard conversations, just saying what's going on to different family members. So it can include that, goals of care, end of life discussions if need be. So they should provide that as well. And then, of course, advanced care planning. So these are the services that palliative care could provide. Like I said before, this is based on each agency. Please do your research. I want to provide this model as something you can use as a tool to know what you ask different agencies, if this is the route you want to start with first, on what to look for and how to gauge what you need to care for your loved one at home. Of course, there should be someone on the team that provides community resources and referrals based on in-home assessments or based on questions you may ask. There are tons of things that a social worker, a nurse, any of the team members may know. So we like to provide that information. But there are things that we don't know you need initially. So we try to kind of do that on an ongoing assessment to see what referrals or community services that can help benefit your loved one and also the family. We like to coordinate with home health services. So typically, palliative care would allow you to have home health in the home as well. So we like to coordinate that. And then if that's something that the family needs, we like to kind of help facilitate that or get that put in place. And then, of course, the freedoms to continue outside of the home, which is allowing you to do dialysis, seek treatment, see your doctors, rehab, go to the hospital, a number of things, but still be able to provide that layer of support at home. A lot of families like to start that way just because they really don't know um, how things will progress. So, palliative care would be a great starting point if you are kind of trying to decide what way you want to go. We normally suggest that palliative care is appropriate for anyone who has a life limiting diagnosis, and palliative care could be initiated as early as when they get diagnosed. So we want to shed insight. We want to provide this information. So if you're thinking about it, or if you have a family that, there's something coming up and we're thinking like, hey, this may be it, we just need to get a definitive diagnosis, you can ask your family member's primary care physician or specialty doctor, hey, I attended this service. They talked about palliative care. What would that look like for my loved one? And if they agree, they will initiate the information that you need to move forward. So, who qualifies for palliative care? Like I said, anyone with a serious life limiting illness. And these are some of the typical ones we get. Of course, we wanted to shed insight on Alzheimer's and dementia. That's why we're here today. Congestive heart failure, Parkinson's disease, which also affects our altered mental status as well. ALS, which is also known as Lou Gehrig's disease, cancer, end stage renal disease, which kind of affects our kidneys as well, COPD, which is kind of respiratory issues, stroke, liver disease, kidney disease, and HIV and AIDS. We've had some other family members with different circumstances, but this is just kind of the standard. And like I said, if what your family has is not listed, just reach out to your primary care physician to see if they may qualify for the services, because we do have other diagnoses. These are just most common. So the next part talks about hospice care, but before I get there, I just kind of want to wrap around with palliative care. So just to refresh, palliative care is a home-based program that provides supportive care in the home, that allows you to still see your doctors, any other outside visits you may have. It also allows for you to seek what we call curative treatments or aggressive care, which is dialysis, chemo, radiation, specialty doctors. Some patients may go to rehab or what we like to call acute hospitals for certain illnesses or diagnoses. Palliative care can be put in place. Palliative care is also offered in the home, also in the assisted living community. Um, some programs may or may not go into nursing homes, just because a full off nursing home provides a level of palliative care because they have a nurse that rounds and a social worker that's there pretty often. But we do go to, or most should go, I should say, to assisted livings, homes, group homes, or any other setting that would allow us to contract with them. We do goals of care. We do particular type of assessments. We look for resources. So we try to get the ball running. Some families already have that put in place. Some families just don't know where to really start. So we like to put those things in place. So that's kind of just a palliative care. Like I said, if you're questioning it, the first thing to do is talk to your primary care physician. Looking at if we have loved ones with Alzheimer's and dementia, you can talk to their neurologist, or if there's a particular specialty that they're looking at, you can speak with them, say, hey, I went to this Lurch and Learn. I've learned about palliative care. What would that look like for my loved one? We also ask families to do their research, call agencies, see what they offer, see what they provide, ask those questions, and just see what will be best for your family. Some patients feel like they may not need palliative care at this very moment, but down the line they may need it. We encourage people to be very proactive, meaning that we would like services to be in place, and that's any palliative care company. we would like services to be in place at that time. That way, when changes happen, or if we need to evaluate that loved one more, those services are already put in place. So I hope that gives you a little bit about palliative care. Like I said, if you have any questions, if you can hold tight to them. I think Miss Ellen is gonna watch that for me. I kind of removed the camera because I felt like I was looking at myself. So if you have any, just hold them tight, or if there's a chat box, if you can write them in there, Miss Ellen will show me at the end and we can kind of go from there. So that's the gist of palliative care. If you have any patient specific questions, if you can get that to Miss Ellen, I can try to answer that as best as I can, generally, but the very best person would be, of course, your primary care physician or the doctor that's most involved in the care of your loved one. So the next topic talks about hospice care. So hospice is a higher level of care that provides a different level of service for patients with that same life limiting diagnoses. So some people feel that hospice and palliative kind of overlap. They kind of do a little bit, but it depends on what you want. So if you have a life limiting diagnosis, but you still want to do some treatment, or you still want to see your doctor, or you still want to try some what we call like aggressive treatments, palliative care may be where you need to be at that time. However, if we're focusing more on a higher level of care, or what we like to say comfort care, we may need to look into the hospice realm. So I'm going to talk about the hospice services in general. The same applies with palliative care. There are tons of agencies in this area. I'm not sure how far we are, but as of our Baton Rouge area, there's over 30 hospice agencies that service this area, and the palliative care realm is growing as well. I'm not sure of the number. It's not 30, but it's growing day by day. So there are 30 hospice agencies. Everyone has their particular thing that they offer. I really encourage families, no matter who you decide, just make sure that fits for your family. Make sure they provide the level of care you need and what you're looking for, but each agency offers something different. I'm just going to stick to the standard of what should be allowed in hospice care. So, hospice care is basically care from an interdisciplinary team of clinicians focused on providing comfort, caregiver support to the patient remaining in their home. So, when we say home, we have to think about home like setting. Now, hospice care is provided in pretty much all settings. So, it can be provided in the home, assisted living, a nursing home, a memory care unit, group home. Hospice is offered at that time. If your loved one is in a different setting, like an assisted living or a nursing home, we collaborate with that team to come up with a plan of care so we all can work together. So that's kind of one of the differences between hospice and palliative, is that they can go into settings where palliative may not. What are hospice care services? So, like I said, this is just the standard. Each agency may have a little caveat or something different that they offer. So, if this is the route we're going, or if this is the route that your loved one's doctor has recommended, this is kind of the standard. But we do encourage to make your own judgment. We, as medical professionals, can't really suggest. We can only advise to kind of do your research and see. Um, as of me, I work with a hospice and palliative care, so I can only discuss what I offer. I won't do that today, but I can only discuss what I can offer in palliative and hospice. But please reach out to those different agencies to see what they offer. Also, if you know any family members that have had palliative care, any word of mouth, church members, friends, assisted living, anyone that can shed some additional insight with you, please use that. I know Miss Ellen and the Alzheimer's team here has tons of support groups and lunch and learns, resources, things where you can possibly connect with other family members that may be able to give some advice as well. But like I said, this is kind of the standard. So, of course, it's an interdisciplinary approach to care. They do scheduled in-home visits by a nurse, social worker, spiritual care, which is a chaplain, a volunteer. Oh, and I'm sorry, I'm spelled that wrong. It should be CNA. I'm sorry, which is a like an aide, in other words. So that should be the standard. Some agencies may offer more, some agencies may offer them differently, and the frequency of those visits will depend on how the patient is at that time when they do an assessment. All hospice agencies are available around the clock. It doesn't mean that they are available at your home around the clock, but they usually provide like a phone number where you can reach a nurse 24 hours a day, 7 days a week. Um, Respite, which is caregiver relief. So some agencies provide a inpatient unit, which is a facility that they either own or contract with that will give our caregivers a break. Some facilities have contracts with other places where they can care for your loved one for a certain amount of days or time while you get a break. As you guys know, caregiving is a hard job. It is 25/8, like I like to tell my families, and we do not judge. We totally understand. And sometimes our family members need a break. Sometimes things happen, emergencies. So respite care is usually offered. It really just depends on the agency on what and how it's offered. Like I said, they do offer an inpatient facility for acute symptom management that can't be managed at home. So sometimes we have patients who have certain symptoms that we have tried multiple interventions or multiple things, medicines, um, any type of intervention to try to alleviate whatever symptom we're trying to manage, and it's just not working. So usually the hospice team will suggest either their inpatient unit if they have one or a contracted facility so they can have more management. And it's usually IV meds. Sometimes they have to adjust the meds and be monitored. So that's also offered as well. Hospice teams are, or hospice patients are supported by a medical director and a nurse practitioner. Sometimes they work hand in hand. Of course, the assessments are ongoing, meaning that every time you get visited by the nurse, the social worker, the chaplain, they're assessing goals for care every time. You may not know it because it may simply be just a conversation or it may look the same, but they're assessing everything every time just to make sure what we're doing is right and also to be prepared for the future. We continually talk about education, what to expect, what to look for, and we're also available to answer any questions. And when I'm saying we, that's as a medical professional with palliative or hospice. And then, of course, the goal for hospice is to manage symptoms. Unfortunately, we're unable to cure our loved ones of what they have going on, but we can definitely manage the symptoms, and that can be pain, nausea, vomiting, certain infections. That's our goal to manage. I like to tell our families that we're no longer treating your diagnoses, now we're treating you. So we're focusing on what you have going on at that time, and we like to treat it. Um, so that's kind of how the services go. It's usually assessed all the time. The frequency of care changes all the time. It's really based on what your family needs at that time. And we just kind of be there, be available, and just be on notice in case anything changes. Communication is the key with both services. So as long as you guys can communicate with your hospice or palliative care team, these things work very fluidly and it's smooth. Um, I have a lot of families that talk about, I don't know what happened before this. I can't remember. Everything works so fluid. So that's really the goal, is to alleviate some of the stressors that our families have and provide some support. In addition to the hospice services, they also provide medical equipment, medicines for pain and comfort. The CNA does hygiene care. Some facilities or some agencies may do wound care, just to make sure the wounds are dry and clean and they're not infected. Some agencies may do palliative therapies, and what I mean by that is that in certain cases, um, some agencies may involve certain therapies that you may see on palliative care. So a person may qualify for therapy for a session or two, or maybe palliative radiation or palliative chemo, depending on the particular case. Each hospice agency does have a bereavement sector in their agency, and depending on that sector, they'll let you know what's offered. And then they have specialty programs. So they may offer additional support in their program. So next we're going to talk about who qualifies for hospice. I'm going to try to stick to the Alzheimer's dementia guidelines, but there are also some other things too. I know we have some families that may be on here or may listen in the future that has a family with Alzheimer's and dementia, but may have another diagnosis as well. So the general criteria is just a progression of a disease that's documented by their doctor. So we are unable to place a patient in hospice. We have to have a doctor recommended, and that's based on their visits, lab work, and any other documentation they would like to provide. Comorbidities or more diagnoses, that's what comorbidities mean, excuse me, that are worsening or complicating their illness. So like I just said, we may have a patient who has Alzheimer's or dementia, but now we have a new diagnosis of cancer. What do we do with that? Or they may have something else that's also life limiting that's affecting their primary diagnoses, which would be either Alzheimer's or cancer or what have you. Symptoms requiring management, such as pain, nausea, vomiting, delirium, or bleeding. A total decline in illness or a catastrophic event. A fall for us or for our loved ones is probably one of the hardest. And just merely going to the hospital, I would say, for our Alzheimer's and dementia families, just being in a different environment with our loved ones sometimes take a toll on them. So falls for us are, we're worried as medical professionals in our field. But a fracture, excuse me, or a brain bleed may also cause your loved one to decline or get sicker or be more ill. Weight loss, that's one of the things we focus on. If we have severe weight loss that causes an issue, we've had certain patients who just don't have an appetite, loses the ability to remember how to chew or do the thing called pocketing, where they may chew the food, but it kind of just sits in their cheek and they're not sure what to do after that. But any weight loss that has happened dramatically over the last 6 months, we need to look at kind of what that's doing and where we need to go from there. And then, of course, just decrease independence, not being able to walk or really know where to go, requiring assistance with bathing or getting dressed or shaving or cooking, even getting out of the bed or going from bed to chair, anything like that does cause what we consider a decline or a decreased independence on someone else to care for them. Also, multiple hospitalizations over the last 6 months. And that can be any level. That can be an emergency, acute care, intensive care. If we're seeing those patterns multiple times within a range of 6 months, we definitely want to look at that to see where we are and to see what level of care that we can offer. And usually that's looked at with either the hospital, the doctors, medical team, and they use these tools to evaluate where we should go and how we should support the family. This is just a continuation of the last slide, but just kind of specifically focusing on Alzheimer's. So one of the tools that medical professionals, doctors, nurse practitioners use is called the FAST scale. It's a tool that is widely used as a method of evaluating where our loved ones are in Alzheimer's. It stages it in 1, 2, 3, 4, 5, 6, 7, and then there's multiple little diagnoses or little things to look for in there. In order for a patient to be considered for hospice, per Medicare guidelines, we need to have our loved one in the seventh stage to be considered for hospice if that's what we're looking for. The FAST scale is available on Google if you want to just look at it and see what it looks like. It's not specific, meaning that your loved one may not meet each criteria, but based on what the nurse and nurse practitioner sees, they're able to scale it based on what they see, and they're able to range it and document where they are. If any of your loved ones are above 7, palliative care may be the best route, or even if they're in 7 and you want to try palliative care first, that is totally your right if your medical professional agrees or if your doctor agrees. But in order for us to consider someone for hospice, this is the guidelines that we use through Medicare. In regards to dementia, it's basically just depending on others for activities of daily living. Not be able to say when they have to go to the restroom. We call that incontinence. Limited to no meaningful communication. And that's usually meaning if they're just not speaking at all or speaking in word salads, meaning that the words are kind of just mixed up together like a salad, or if the conversation is not flowing along with what someone is saying or what you're saying with the loved one. And then, of course, unattended weight loss. So although when we talk about memory deficits, we kind of do Alzheimer's and dementia together, the qualifications based on the guidelines we have to abide by look a little different. A dementia diagnosis does not necessarily look at the FAST scale. It mainly focuses on what the loved one can or cannot do in regards to activities of daily living, which is dressing, bathing, toileting, weight loss, those type of things. And of course, I didn't want to not discuss other diagnoses that fall under hospice. And this is not everything, y'all. This is just kind of what we see the most. Of course, cancer, congestive heart failure, respiratory disease, liver disease, kidney disease, and HIV, AIDS. There are other diagnoses that fall under here. Of course, ALS, Huntington's disease, which is similar to ALS, but it also affects the motor functions in their brain. So it's not limited to these. These are just more common. So like I said before, with either program, if you feel like your loved one has a life-limiting diagnosis, the best thing to do is speak with your primary care physician or specialty doctor to discuss what services can you get and what's available to your loved one. So I wanted to touch on this just a little bit. You guys will never see this, but I just kind of wanted to show what it looks like and what has to be done in order to ensure someone is on hospice and what we have to do to make sure we meet the guidelines. All hospice agencies must follow Medicare guidelines, even if the patient is not insured by Medicare. Those are the guidelines we follow, and it's basically making sure that we're documenting right and that the hospice agency is providing the level of care that's needed based on those guidelines. So basically, this is what's called a certificate of terminal illness. This is required from each hospice medical director that basically states that hospice is appropriate for this person. The hospice physician decides based on the information about the patient, using their medical expertise, documentation, visits, lab work to determine hospice eligibility, and they actually have to sign off on it. So that goes back to saying we can't just place anyone on hospice. We do need a doctor to kind of recommend that because we do require them to sign off on that as well. So I just wanted to touch base on that just a little bit. So like I said earlier, some people feel like, and I kind of agree, but some people feel like hospice and palliative kind of overlap, and they do as regard of diagnoses. So I just kind of wanted to list the most common diagnoses. I didn't mention this earlier, but some people also use senile degeneration of the brain, which is another level of Alzheimer's and dementia. So I kind of put that in parentheses, but it's Alzheimer's and dementia, cancer, cardiac events, respiratory events, end stage renal events, and also ALS. And like I said before, it's just common, but of course, there are other things that go with that or other diagnoses that I haven't listed that may also qualify for palliative and or hospice. So I wanted to kind of just give you a little part to screenshot. This is Alzheimer's and dementia with palliative care versus hospice to kind of show you what the differences are. Now, this is not required, meaning that, oh, you're in late stage, you can't be on palliative. You can, you have the right to decide, but this kind of helps you determine where you should be or where you can be if you're looking for additional care for your loved one at the home. So palliative care is, of course, early to middle stages. Like I said earlier, someone may qualify for palliative care at the moment of diagnoses. If your doctor feels like it, or if you mention it and your doctor agrees, some people can get palliative care literally the moment they're diagnosed. And that's just to make sure the family is supported, they have what they need, and they can start their care from there. So early to middle stages, forgetfulness and confusion, personality changes, and then beginning to have difficulties with activities of daily living or ADLs, like we call it for short, and just needing more help. Continuing memory enhancement medications. So some people use, or most people use, Aricept or Namenda. Y'all probably know what those are. Not to say this is the only medication that's used for our loved ones with these diagnoses. These two are just the most common. Also, continuing to attend your neurology appointments. So that's why palliative care is very important, especially if you're starting in these stages, because you're still trying to find things out, but you still need to be supported as well in addition to what you have. So y'all are still doing MRIs, doing diagnostic tests, running lab work, just trying to figure out where you are in the scheme of the process of their diagnoses, but also being supported as well. And then, of course, if you have the desire to continue aggressive treatments, such as going to the doctor, um, doing physical therapy, outpatient therapy. If you have wounds that require like wound care, like intensive wound care, any injuries, anything like that, that still allows you to seek palliative care. So if your loved one kind of meets some of those, or if that reminds you of your loved one, palliative care may be the best place to start. For hospice care, which would be the latter stages of Alzheimer's or dementia or any memory deficit, because I'm not excluding all of the other ones, Lewy body dementia, vascular dementia. There's so many others under this umbrella of memory deficit. I don't want y'all to feel like I'm not including y'all as well, because I'm not saying that, but this is all memory deficits. So, in the latter stage of the diagnoses, nutritional changes resulting in possibly choking or weight loss, if we have to do a soft diet or puree diet just because swallowing may be difficult, if we're sleeping more throughout the day, and when I mean sleeping more than 14 hours a day. If we're easily agitated by things that normally happen, having two people conversate and your loved one with Alzheimer's and dementia is there, if that agitates them, if they begin to lose their speech or struggle with ambulating or walking around, or even just knowing where they're going, we call that cueing, where you have to tell them or direct them where they go. Of course, requiring assistance with the activities of daily living. So that's like bathing, dressing, toileting, transfers, walking, feeding, even as far as combing hair, anything like that, if they require assistance with most or if not all of those. And then recurring infections, which is urinary tract infections, pneumonia, and sepsis. So if we're starting to get those more frequently in the latter stages, hospice may be more appropriate for your loved one. Of course, if we're going to the hospital a lot, like I said before, if we're going to the hospital a lot within the last 6 months, that particular hospitalist or when the primary care physician follows up, they may see a pattern and say, okay, hey, we need to look at this. This is what I'm thinking. We may be at this stage. And then hospice conversation may be discussed at that time. And then, of course, if we're getting like any sores, I like to call them bobos, but if we're getting any sores to the skin that are just not healing, we may need to look into hospice care. So, hopefully, this kind of sheds insight on where you should be if you have a loved one in these areas. Um, Neither one of them say you must be in these areas. This is just where you could be or where you should be if you decide. There's no right or wrong. You have the right to choose whatever service you want, but just know for the hospice side, there's definitely a criteria we have to meet. So most families would start off at palliative care to where their symptoms are monitored along with their doctor's visits. And then if they have a program that allows them to transition to hospice, they can do that as well when and if the time is right and the family is ready, because you have to be ready for that as well. And just final thoughts, like I was saying, none of these are required. These are just guidelines. I hope I was able to shed some insight. I hope I didn't talk too fast. I have a habit of doing that. If I did, please re-ask the question. I don't mind. Um, I'm here and available. Like I said, if you have any questions now, that's great. If you think of anything, please reach out to Miss Ellen and we can make sure we have those answered for you. But like I said, none of these are required. They're all guidelines. We just want to give you the information so you know where to go. Hospice has been around for years. Palliative care, it's not new, but it's evolving. And we want to be able to get the message out there to say, hey, there's this other program that can offer you some support as well. I've always said this, even when we were discussing building our palliative care program, sometimes our families need to have a moment to just process everything, but also be supported. And I'm just going to speak for everyone and say that's why all of our programs were created. For palliative care, the patient should have one or more serious illness and the desire to focus on comfort and decision making for their care. For hospice care, regardless of the diagnoses, it does say a 6 month or less prognosis by a hospice physician is required, but that doesn't mean, oh, after 6 months, if our loved one is still here, you got to be out of hospice. That's not the case. Hospice has also evolved tremendously over the last couple of years. We are able to, and when I say we, hospice and palliative care, but hospice in general, we are able to document to our providers that say, hey, this patient still requires these services, although it's past 6 months. So I know years ago, or even when I first started, the stigma of, oh, it's only 6 months. I feel like my family has longer. Well, they may. Some agencies have had patients on hospice care for a couple of days. Some people, or some agencies, excuse me, have had hospice patients on their service for years. It's their journey. We just want to support them on it. So this is just a medical declaration that says a prognosis of possibly 6 months or less. So for hospice care, regardless of diagnoses, a 6 months or less prognosis by a hospice physician is required, as well as the patient's decision to forego life-prolonging medical treatments. So the hospice director or the doctor who's referring hospice may suggest it, but you must agree to it as well. If you're not ready for that at that time, palliative care may be the best way for you, where you can start and go from there. But all of our suggestions are just what they are, just suggestions. Patients who qualify for hospice by having a 6 month or less prognosis may still qualify for palliative care if they're not yet ready for the philosophy of hospice care. They may just not receive the depth of care that they receive. So, like I just said, you may qualify for hospice and you're just not ready just yet. We may need to do palliative, but the services look different. Most palliative care agencies will not see a patient every week like you would in hospice, but we build that plan of care based on the patient. So if you're thinking about palliative versus hospice, the visit frequency, like how many times they're going to come, is probably an important question to ask. If you feel like you need more visits and you're focusing on comfort, hospice may be where you need to be. If you still want to go to the doctor and you're okay with us visiting not so much, or if you still want to get those aggressive treatments, I still want to go to the doctor, I still want to do this therapy, then palliative may be the best for you. And then, of course, if you're not sure, please reach out to your primary care doctor to help decide which course of care is right for you. They'll be able to make the best recommendation and point you in the direction that you need to go. What I would ask for our family members is just to look at different agencies, because every agency offers something different, to see which one would align with the goals and philosophies or practices or beliefs that you may need for your loved one. So that's really it. Just to kind of recap, palliative is more aggressive. It allows you to still go to your doctors. It provides certain services with a time frame or a frequency based on what they offer. It's really agency specific. They do goals of care, community resources, support to the family, as much as they can within that scope. Hospice care is frequent visits. It's also depending on how the patient is at that time. The visits are at least weekly by multiple members. They do offer an inpatient unit or a contracted inpatient unit if not. They're available 24/7. They offer more as far as medications, equipment, an aid, those type of things. So there is a difference, but I always tell our families you have to go with what feels comfortable with you. We as professionals do not want to put you in a service that you're not ready for at that time. But however, we want it to be open and honest and be able to tell you, hey, we need to start with palliative care, or hey, we may need to focus on hospice. But each one of you guys have the right to say yes or no. They're just guidelines. So I hope all of this shed some insight. I hope I didn't confuse everybody. But if y'all have any additional questions, Miss Ellen, can you help me if they do? Because I can't see it anymore. I
Yeah,
don't know.
Karen, absolutely. Absolutely. I just wanted to say, first off, thank you so much. That was a fantastic presentation. I think you did a great job of like really shedding light and providing a lot of clarity on
Mhm.
the differences between palliative and hospice. So thank you so much for that.
Anytime.
If anybody has any questions for Karen, go ahead, feel free, put them in the chat. I did see one so far, Karen, and then I have some other ones too for you.
Okay. I can't see them. So if you can just,
Yeah, I'll read them to you.
okay.
Your first question says, does insurance pay for palliative care?
Yes. So each agency is different, but we do attempt to bill your insurance for reimbursement. So yes, ma'am.
Thank you. All right. I know you talked about this a little bit towards the end of the presentation,
Mhm.
but just to dive into a little more into it, can you talk about how often, maybe on average, or kind of what the standard would be for how often a palliative care staff member or team member is visiting with a family in the home?
Well, so generally it's usually a few times, maybe a month, and that's from each member. It really depends on what they see. So a nurse practitioner may visit once every 3 to 4 weeks. The social worker, depending on the need, may visit a few times a month, especially if they have to do goals of care, follow up on resources. It could be multiple times. So if I'm working with a patient and they don't have an advanced care planning, or I need to help them do like a waiver for a service that may help them provide caregivers in the home, that may require multiple visits. Palliative care is not mandated, I will say that. So we don't have any like regulations on how much or how less we can come. Some agencies may offer a chaplain that's based on the spiritual need of the patient. Some agencies may offer like a volunteer or a different service or what have you. And it really depends. So I can't really say, but based on what I've normally done, it's like that. So a nurse may come maybe once or twice a month, social worker about the same, chaplain maybe about a month. It just depends on where they are, especially if we got someone that got diagnosed maybe like a month ago. It may be a lot of visits
Hmm.
versus someone who was diagnosed 3 years ago. It may be once every 3 months.
Okay.
It really just depends. So usually on the initial visit, we kind of talk about that. And if the nurse feels that there's a lot of things we need to manage, she may scale her visits on that. If I'm the social worker and I feel like we need to go through this, and this, or if the family is open to all my suggestions, I have to follow up on that. So I hope that answers but it really just depends at the same time.
Yeah, that's very helpful. Thank
Mhm.
you. We have a couple more questions that have popped up in the chat. Someone asked, where do we start? Like, if you're interested in getting services, where would you recommend a family start?
Your primary care physician or the doctor that's most involved in your care, just to see what services they think your loved one qualifies for, either palliative or hospice. Then after that, you can go to either medicare.gov and look at the ratings of each agency, because I usually tell people to do that because I can't really suggest anywhere, or Google. You can always Google palliative care agencies in Livingston, in Baton Rouge. Word of mouth also works as well. If you know someone that has a similar diagnosis, or if you know someone that, oh, I know Miss Mary down the street gets a lady that comes to see her a couple of times a week. Let me see if she's okay with sharing what she has. And she may know of an agency that may fit. So, but in order to see what you qualify for or where you may need to start, your primary doctor.
Thanks, Karen. And we can also help in that process too. Once families are
Mm-hmm.
interested in services, if they need names of agencies, things like that, we can add to that too.
Yeah.
Next question is one-on-one counseling for caregivers covered in either of these types of services?
So yes, the social workers provide a level of counseling. However, we're only mandated with our scope of practice. So if it goes beyond our scope of practice, then we'll have to refer you out. So I know, for instance, I have a cancer patient that requires more than I'm allowed to offer based on my scope of practice as a social worker. So I had to refer her to a clinical social worker with cancer services, and we set that up. And usually agencies offer that as a free service, but if it's something that they have to pay for, I try to help them go through their insurance and find something in network, and then try to reach out to see if they offer virtual versus in person. If there's a copay, I try to do as much as they allow me to do before they say you're not family, I can't tell you nothing.
Thank you. Our next question is, how can hospice support if the person is too young to qualify for Medicare? So like an example would be maybe a person diagnosed with like an early onset type diagnosis at like 55. What would you recommend for that?
So if they still qualify for hospice and don't have Medicare, that's okay. We just follow Medicare guidelines for documentation. Most hospice agencies take most insurances, and then there's some agencies that take every insurance. We have agencies or hospice agencies that take babies, preemies, peds patients, or what have you. So Medicare is just the guideline that we use for documentation, but their insurance may cover hospice. So Medicare, traditional Medicare, Humana, any type of Medicare-ish plan will cover hospice at 100%. Most Blue Cross Blue Shield plans will as well. I always tell families with Blue Cross Blue Shield, call first. Some Blue Cross Blue Shield plans don't cover at 100% unless you meet a certain deductible. But if it's a child and that child qualifies for hospice and their insurance accepts hospice, they'll be fine as long as the agency they select will select that young person. We just follow Medicare as far as guidelines to document our particular visits and things like that. I hope that answered it.
Yeah, that was very helpful. Thanks,
Okay.
Karen. The next question is, what would you say to a family who's maybe afraid of hospice or has some fear associated with starting hospice for their loved one?
Oh, I love this question.
Hmm.
So that allows me to be a social worker. So I usually ask why, and it's a few things. Let me say this, and I'll say what the few things are, and I'll say what I'll say. So it's usually the stigma of hospice, the hospice word, or that they're giving up. So when
Mhm.
they say, "Oh, well, I don't like the hospice word," well, we don't have to use it. We don't have to use it. If they say, "Oh, there's a stigma once you get on hospice, that means that's it." It doesn't. We don't take anyone's dignity away. We don't make anyone do anything. We don't come in and dictate everything. This has to be an agreement with your doctor, us, and you. But at the end of the day, you lead. We support. We're limited in how we support. We're limited in what we can do. Those things are comfort. I would try to dig deep to see why. Um, there's a lot of examples I can give. I just hope that whatever example I give, that may be what that person is thinking. But some people just had a bad experience with hospice. They may have a loved one who got on hospice and passed away really quickly. There may just people just heard things over time, or just the stigma of it. So as a social worker, we really want to go in as deep as they would allow to kind of figure out what that is. Some people are not willing to accept their diagnoses. I've never experienced that. I don't know how I would feel if someone told me what, like I had a terminal diagnosis or anything like that. So if they're afraid, even before or after, I would encourage them to reach out to someone with a hospice agency, maybe someone you know, or a social worker or something, to talk about it. It may be something as easy as, well, my mama takes blood pressure medicine and I heard that hospice is going to take her off. No, we're not. So it's so many reasons, and we want to validate them all. But the reason why I do this and the reason why we go in the community is just to educate, because things have changed so much with palliative and hospice, and it's such a benefit for people who deserve it, not need it, deserve it. Now, there's a lot of people we can't catch on time. There's a lot of people that prefer to just not choose it, and that's their right too. But I would encourage that person to either speak with someone or call an agency and ask a question. Ask to say, "Hey, I'm calling. Can I speak to a social worker? I have a general question. I'm afraid about this. Is this something that you would cover? Is this something that you would do?" So there's a lot of ways to do it. I hope the reason that you were afraid, I may have kind of shed a little light on that. Um, if you're open to expound on that, please feel free to maybe send Miss Ellen an email, and maybe me and Miss Ellen can look at it together and we can answer it appropriately, based on your situation. But it's a lot of scenarios. But I would say don't sit in your fear, get your question asked, because that can determine if, okay, I'm not scared, I know I don't want it, or okay, I'm not scared, I'm glad I asked.
Thank you, Karen. I think that's a fantastic answer.
No problem.
One more question in the chat. Is there any financial assistance programs that maybe you're aware of for caregivers? And if so, where do we start with that? And I can also add on to this with you too if you want to.
Okay, perfect. Because please add on, because I know you have something. So there's a few. So there's a few with the Alzheimer's community, and I'll let Miss Ellen do that. So there are not so much as financial assistance, but there are some programs in the community that your loved one may qualify for. The two I shed on is for community choices waiver and the long-term care attendant, and you can Google them both. And I think Miss Ellen may have it. I think I saw it here. But those two programs are funded through insurance. Community choices waiver, you must have Medicare. There is a waiting list. I'm not sure how long that is, but if you Google community choice waiver flyer, it will pull up and show you what the flyer looks like, what it offers, and also the income limits or guidelines. So there is a waiting list. However, if you are approved, your loved one can get up to 73 hours a week of caregiving in the home. That's usually during the daytime hours. Most, if not all of the waiver programs outside of children do not offer like evening or around the clock care. If a loved one that's an adult that needs around the clock care, the state would suggest nursing home placement. The second program is long-term personal care, excuse me, that's also offered through the state. You can Google that as well and just put long-term care flyer. It'll show you that as well with the guidelines. Now for that program, you have to have Medicare and also full Medicaid. That program does not have a waiting list. It does show you the income guidelines and what they offer. And if approved, you get up to 32 hours of caregiving assistance. If your loved one is a VA, I would say if they're already set up with the VA, please contact their primary care physician so they can set them up with a social worker or a direct service worker to be set up with any services that they may qualify for. Because although we're a VA, you have to be at a certain percentage. And I want to make sure I say it right because there's a social worker on here that I just went to a training for a few months ago and she showed us how to do it. But if you have a person that's in the VA, they have to be an affected disabled veteran to get certain benefits. Um, Other than that, I was told people's health provides something. Um, and then of course, Alzheimer's services. So I'll let Miss Ellen shed a little light on that, has some resources too.
Yeah, so another thing that families can utilize that we have here is called respite reimbursement. And if anybody has any questions about it or would like to apply for it, you can always call our office and receive the application from us. But respite reimbursement essentially helps to reimburse families for a portion of the cost of in-home care. So we can reimburse a family up to $1,000 a year if you have a caregiver, like a sitter, whether that be from an agency or private, coming into your home, we can help to reimburse you for that. So people that are in our 10 parish service area can qualify for this. So give us a call and I'll put our phone number in the chat. Give us a call if you have any additional questions about that, or like I said, would like to apply for that. We're happy to provide that information to you. But Karen, we are right at that 1 o'clock hour. So I just want to say thank you again for all of the information that you have provided here today. You've brought so much insight and education to this group. So thank you so, so much. And we thank you again to everybody also who has attended with us today as well. So thank y'all for
Thank
everything.
you.
All right. Thank y'all so much. We'll see y'all for the next one.